Okay, I have the pleasure of discussing fat pad augmentation with all of you today. I know this is a cosmetic tract, but I do believe that these procedures extend far beyond just cosmetic use. I think there's a lot of utility for everybody in this room. I have no financial disclosures. So the hope of this is that you all will be able to identify and diagnose fat pad atrophy, understand how we can augment that atrophy and utilize those techniques in your office. I'm going to compare autologous versus exogenous with a focus on exogenous, as I think that that is the most utility for all of us in the room today, and no advanced training for those, so a lot of people will be able to utilize that. So fat pad, as most of us know, is that dense cushion of elastic adipose tissue, primarily located in weight-bearing areas, so the forefoot and the heel, and to a lesser degree, the toes. Atrophy of that fat pad is when it starts to thin or displaces distally, and they lose that absorptive shock reduction, and that can lead to pain. So causes of this, there's several. Aging, of course, you lose collagen everywhere in your body. The fat redistributes, and you also have changes in the quality and quantity of your adipose tissue. Repetitive stress, altered biomechanics, certain medical conditions, diabetes, your arthropathies, any of your collagen conditions, and iatrogenic, of course, after surgery or injections, multiple steroid injections, and trauma. Patients usually present with pain. Sometimes they'll present explaining that they feel like they're walking on a pebble or have something pushing up underneath, or just increased sensitivity. Most of these patients will say that they do not walk barefoot at all at home and have not for several years because they're not able to because of how uncomfortable it is for them. So diagnosing fat pad atrophy, there are several modalities. I obtain x-rays and ultrasounds on all of my patients. You can use a gate plate to kind of show your patients the pressure areas or high peak pressure areas. MRI not often used unless you're trying to rule out another pathology like a plantar plate injury. There's no established criteria for diagnosing fat pad atrophy or the exact thickness that we're looking for. So this is clinical diagnosis or a diagnosis of exclusion. So here's some x-rays. As I said, I always get these. It's important to see kind of what the osseous pathology is or what's going on underneath. With ultrasound, we can actually measure the thickness of that fat pad. So there is very little literature or reports on what the standard thickness is or should be. In our office, we measure from subdermis to the cortex. So I know this incorporates some other structures, but this is the best way that we've found to just make a reproducible way to measure. This gate plate analysis demonstrates the decrease in peak pressures in the forefoot, especially significant underneath sub 5. Here you can see an MRI on the left is before fat pad augmentation. On the right is 18 months after treatment, and there's almost a ½ centimeter increase in the fat pad thickness. Fat pad restoration is a series of procedures aimed to restore that thickness of the subdermal and subcutaneous layer, and that allows us to recreate that natural shock absorption. Most of these procedures can be done in the office, and they're slowly gaining national recognition and have been for the last decade. Atrophy occurs primarily in those high pressure areas, which leads to pain or pre-ulcerative lesions, and in your neuropathic patients, ultimately ulcers. So we restore that fat pad in various ways to address those concerns. The dorsum of the foot is for pure improvement in cosmesis. So as I stated before, I think that this has a utility in everybody's, almost everybody's practice or office. There's a wide spectrum of treatment options. So on the very conservative end of the spectrum, you have a patient who has a callus that you continue to debride down, maybe use orthotics or offloading padding, but they're going to continue to come back every couple of months. On the other end of the spectrum is surgical reconstruction. A lot of these patients are sick and you're not able to take them to surgery to do the reconstruction that they would need. So fat pad augmentation or restoration is that sweet spot treatment kind of area in the middle where you don't have to continually just keep scraping down every couple of months and you don't have to have the patient commit to surgical reconstruction. Most of these procedures can be done in the office with minimal downtime. Here's a whole list of conditions that we can address with this augmentation. Of course, diabetic ulcers, as long as they are not infected, so stages 0 to 2. Any mechanically induced callus or preulcerative lesion, connective tissue disorders, which we see often, traumatic atrophy, like after a calcaneal fracture or other type of fracture, tissue scarring, whether it was after an injury or previous surgery, this can be used for, corticosteroid-induced lipoatrophy, and things related to sports injuries or cavus foot when you have that anterior displacement of the fat pad. And then any other of deformities that lead to pain and atrophy of this, like your bunions, bunionettes. So here's an overview of the options that we have to restore that fat pad. Off-the-shelf injectables are either made from naturally derived or synthetic materials. The synthetic materials last longer. The natural ones are broken down by your body much faster. The PLLA and calcium hydroxyapatite actually stimulate collagen production. So those products are going to take longer for the patient to see an effect or have a benefit, whereas like your hyaluronic acid is going to draw water into the area so you have an instant plumping effect. So patients have improvement right away versus having to wait the time period for the stimulation of the collagen production. So most of these off-the-shelf injectables are fillers that are used in the face and they are FDA approved elsewhere in the body. And we use them off-label in the foot. There is one adipose allograft matrix designed for the foot. It is essentially donated human adipose and that it goes through processing and is made into injectables. And so you take the fat, get rid of the lobules, and then you're left with this matrix or framework that you can inject, and then that stimulates adipogenesis. We have surgical allograft insertion as well as another exogenous. This is when you take an allograft and actually, in the operating room, both 2 and 3 here, surgical allograft insertion and fat transfer are usually reserved for the operating room. As far as the fat transfer, that's when you need large volumes. And you would take the patient to the operating room for that. So for our exogenous fat pad augmentation, there are several advantages. This is minimally invasive. You don't need to do any harvesting of fat graft. You basically just in injection. That's most. I'm kind of going to focus on the off-the-shelf as that's most utility for us here today. So simply just an injection. These products are easy to use, readily available, and you have consistent quality. Some provide immediate relief, like I had said before, like your hyaluronic acid, where others take a little while to see an effect. As far as disadvantages, there is a potential for allergic reaction or rejection by the body. Products may need to be re-injected. Your patients may come in for, we call them touch-ups periodically. Injectables usually last about 1 to 3 years, but that's not something we can exactly predict. So that's a conversation that I have with my patients. Somehow it's going without me clicking. Okay. As far as cost, these, of course, all of these can be costly. And so what we do in our office is have the patient put a 50% down payment down, and then we hold that, and then on the day of the procedure, they pay the other 50. The reason for that is some of these products you have to mix in advance. So it's important that they kind of pay something up front for that commitment. As far as similar to any other cash pay type of procedure, you want to charge, about 3 times whatever the cost of the product is. And product cost is going to vary depending on kind of your area, how much product you're ordering, different things like that. So these are simple procedures which is easily integrated into regular clinical practice with minimal training. There is a high satisfaction rate due to the quick results for some of these and the minimal downtime. Patients are very happy with this. It is suitable for a wide range of patients, including those without sufficient fat, like body fat, to do an actual autologous fat transfer, or for patients who are not super healthy and would not be a candidate for that. So here are some videos on injection techniques. I don't think I'm able to play them because we don't have like a computer or a mouse, but you'll use an 18 to 21 gauge. It can be a sharp or blunt. On the bottom of the foot, I always use blunt. If you're doing like hammer toes, like the lesions on the top of the hammer toes, as you can see in these pictures here, then I would use a sharp, just because it's a very small little area. Oh, you can see it's going. So I use cold spray first for those, and then you go in either with the needle or the cannula, you make your pathway, and then you inject slowly on your way out. You want to inject just little amounts, or like little amounts of the fluid on the way out. You'll redirect about 15 degrees, depending on how big of the area you're covering, 15 to 30 degrees, and then you'll make another pathway and again inject on the way out. You'll want to do at least 3 to 4 passes on the bottom of the foot for one specific area. If you're just doing the toes, you don't need to do that many multiple passes. You really just go up underneath, and you want it to just fill enough to see that blanch like you do on that second picture there. When you're in the toes or somewhere close to a capsule, it's really important that you stay right underneath that skin and don't get anywhere close to the capsule so you don't get capsulitis. These articles down here at the bottom are how I developed my injection technique, so based on the standards for plastic surgery, and those are some articles from plastic surgery literature. So quantity of how much you inject depends on location and the degree of atrophy that you have. So toes is usually about a half cc. One area in the forefoot will be anywhere from 1 to 1.5. If you're doing 2 areas, anywhere from 2 to 3. And the arch and the heel tend to take more, 3 to 4. What we find, people often don't inject enough. Autologous is when you use, so on the other end of the spectrum, we have the autologous. That's when you use the patient's own fat, so you would harvest the fat to restore that atrophy. This is reserved usually when we need higher volumes, somewhere 10 mLs or more. And at that point, injectables would be too costly, so we would take the patient for this autologous graft. Advantages of this is that there's no risk of reaction. You're using the patient's own tissue. It lasts longer than the exogenous. These last about 3 to 5 years. Disadvantages, it is more invasive, requires specialized training and equipment. You are limited in the amount of fat you can obtain, especially if you have a very petite person. And then on the other side, if you have somebody who is very heavy, the fat actually isn't going to be good quality fat. So you'd be better off doing an exogenous product or injectable. BMI of 35 is the cutoff fat we use. These products are generally more expensive. Fat transfers start at $3K and go up from there. So fat transfer can be performed in the office depending on where you are. In Florida, our scope of practice is soft tissue to the hip, so if we're able to get from the calf, we can do that. We can take from that posterior medial calf and be careful of the saphenous and make sure to use blunt. If we need larger volumes, then we would go to the operating room and have a plastic surgeon colleague assist us in that case, taking the using the liposuction to obtain the graft. You can ask your patient where they would like contouring to determine where they take that graft from, usually common places, abdomen, buttocks, or the thighs. Here is a depiction of the Coleman method for obtaining and processing, which is a commonly used technique. And injections for those is the same type of injection technique after the obtaining and harvesting, the harvesting processing. So post-injection offloading, my patients always leave with instructions, post-op instructions, as well as extra pads. I have the patient take a photo on their own cell phone so that when they get home, they have a picture of how to reapply the pads. So there's nobody calling the office and asking these questions. So they take out their phone, we take a picture, have the assistants take a picture for them so that they always have that, and we send them with the extra pads. They also get a post-procedure shoe pending on where we're injecting. If it's on the bottom of the foot, they'll have the pads in the shoe. If it's just the toes, that's not necessary. Depending on the product I use, the patients will offload for 2 weeks. If it's not just hyaluronic acid or something that's instant, if it's one of the other products, then they need to decrease their activity and kind of take it easy for 2 weeks to allow those vascular connections and channels to develop. I always explain it to my patients as, I'm pretty strict with this, having them give me that 2 weeks so that they can protect their investment is how I explain to them. We want the product to stay right where we put it and not have it distribute elsewhere. This is a 60-year-old female who had a flat foot reconstruction approximately 20 years ago. She had significant pain and was not able to play tennis anymore. She was now also developing pain on the other foot just from compensating. She had a pretty significant pre-ulcerative callus sub-first met. The pictures don't really do it justice, but the bone was really right underneath there. It was almost like translucent down to the bone with no cushioning or protection underneath there. So I did fat pad restoration on her, and you can see that immediate kind of plumping effect in that middle picture, which is 1 week after the procedure, and then 10 weeks later, the lesion was completely resolved. This is a fifth Met malunion patient who had a pretty significant history, had osteomyelitis, IV antibiotics, pretty significant course, and I'm skipping one ahead, sorry. This patient had cavus foot or high arch with some displacement of that fat pad distally and a pressure point that we injected. And you can see 13 months after the lesion is completely gone. Here's the fifth Met malunion that the patient needed antibiotics. The lesion did resolve, and at 17 months after the injection, they still had complete resolution of that lesion. This patient had a grade 1 ulcer as well as peripheral arterial disease. The photo on the left is prior to injecting. The central photo is 15 months after injection, and the photo on the right is 30 months after, so you can see that wound is healed. This is a neuropathic diabetic with that capillary bleeding into the callus. The ultrasound imaging here is pretty interesting. So the first image is pre-injection. The second one is immediate after injection. You can kind of see it's just like a hazy mess What's most significant here is at 10 weeks after the injection, you can see that increase in thickness and increase in that hyperechoic signal, or the quality of tissue. That quality of tissue is significantly better there. So here are some possible adverse reactions that we can have. Of course, you can have injection site cellulitis. That's usually based on technique, so you want to make sure that you just prep well prior to doing the injection, just as you would with anything else. If you do end up with cellulitis, these usually resolve with just a short course of oral antibiotics. Localized capsulitis occurs when you enter into the joint or you just catch that capsule, which can happen especially in the toes when there's not a lot of soft tissue kind of there to protect, so you want to be careful of that. This will resolve with a short course of anti-inflammatory medications with no long-term consequences. So the capsulitis will present earlier than your cellulitis. So if your patient contacts you the day after with redness, it's usually associated with that capsulitis first infection. Of course, there's a potential for an allergic reaction or a rejection if we are using any exogenous products. You want to make sure that you aspirate so that you don't end up with vascular insult or a fat emboli. So the big holdup for FDA approval was the fact that they were worried about, especially ejections in the face. If they were to inject into the orbital, that could lead to a TIA. So every time you want to make sure, if there's any vessel, you want to make sure that you're aspirating so that you are not injecting into a vessel. And that's all I have.
So there was a question that was sent up, and
At the end, I think we all come up and sit there.
Sounds good. All right, Tracy's coming up, and she is now at the school, right? Yeah, and she's going to be giving her talk. Any questions you guys have? We're going to do it at the end, so we're going to go through all the talks and then go from there. All right, thank you.
All right. So this is a talk about neuromodulators of the foot, really specifically one that we use mostly. My potential conflicts of interest are the following, but really don't relate to this lecture. So I'm going to talk about the use of neuromodulators, specifically onabotulinum toxin A for hyperhidrosis, plantar fasciitis, and neuromas. So Clostridium botulinum is the bacteria where we derive this protein from. And basically it's an exotoxin that consists of a heavy and a light chain joined by a disulfide bond. There are several different types of exotoxins, but again, most of the time we're going to be using botulinum toxin A. So we can call it BTX, botulinum toxin, all different things. And how it works is that it binds to the local nerve endings and it stops the release of acetylcholine as well as substance P. So the acetylcholine blockage certainly helps us with muscle movement, right? Doesn't allow muscle movement to happen. That's what's happening when you inject it into your face. But the substance P is going to affect our periphery sensory nerves. So if we have, ultimately what I use this mostly for is hyperhidrosis. So if there's no message to the eccrine sweat ducts, we don't get sweating, right? Or reduced sweating, and that's kind of the goal. So what's available? Well, there's several. Onabotulinum toxin A, which is the most popular. I can't say the brand name, but I think you all can figure out which one that is. Avabotulinum toxin A, Incobotulinum toxin A, and Rimabotulinum toxin B. So those are all the generic names for the 4 that are commercially available. So what is in a bottle of onabotulinum toxin A? Well, it's 100 units, it's standard, of the purified protein along with human albumin and some sodium chloride. It's vacuum dried, so when you get that bottle, if you've never gotten it before, it looks like there's absolutely nothing in it. It's kind of a strange experience. Now that said, when I receive these bottles, I keep them in the refrigerator, the med refrigerator, and it's usually can stay there for about 2 years, but hopefully you have a patient set up that you're not waiting for it to be used for 2 years. Now, when I was doing my dermatology fellowship, we were taught very specifically to reconstitute it with non-preserved saline. However, over the years, what I have found is that I don't have to use non-preserved saline. I can use preserved saline or bacteriostatic saline, or I can just use lidocaine with epi or without. So what I have in the last probably about 3 years have started to do is reconstitute onabotulinum toxin A. Now you know which one I'm talking about. With lidocaine. So that's what I have been doing. But also in the beginning, when we didn't know as much about it when we were injecting it into people's faces, because that's how I started, I was a dermatology fellow, so I was injecting into people's faces, wasn't doing the foot, was that we couldn't shake it, we couldn't invert the bottle because it would just, destroy the lesion or destroy the solution. So we would have to just kind of rotate it. Now you can do whatever you want to it. So again, things have changed since I was trained many years ago, and now I can just manipulate that bottle however I want. It's not going to change anything with the solution. So once you reconstitute it, it is good for about 6 weeks, but again, chances are, and how I always use it, I use the whole bottle that whole day on that one patient. I mean, that's what I'm ultimately trying to do, because I'm using this mostly for hyperhidrosis. And so we have patients who have either primary focal hyperhidrosis or something secondarily, which could be related to thyroidism or medications that they're on, or even diabetes. But when I am trying to get insurance coverage, because ultimately that's what I'm usually doing with this, is I'm getting the insurance to cover the bottle, is I have to say the age of onset, if it decreases or increases at night, and if it impairs their daily activities. I've had patients come in where their feet are just dripping sweat, like a faucet right in front of me. I've also had patients complain that they can't wear flip-flops or sandals because they walk right out of them. So these are patients that certainly benefit from this. So the differential diagnoses that we have are pitted keratolysis and erythrasma. Certainly I've seen a lot of pitted keratolysis that also has bromhidrosis along with it, so there's certainly an odor, and hyperthyroidism. So any patient who comes into me who has this new onset of sweating that they didn't have as a teenager or didn't have it as a young person, I will make sure that they will get blood work to look at if they have any thyroid issues. Diabetes, we all know that there's a lot of gustatory sweating with diabetic patients. Well, certainly we can see that in the feet as well. Menopause, some of us are kind of hitting there, and we understand what hot flashes are like. Chronic alcoholism, and of course, tinea pedis. But one of the websites that I always send my patients to is sweathelp.org. Sweathelp.org gives them a lot of resources for products that are over the counter. There's insoles that are antimicrobial, that absorb sweat. There's socks. There's all different kinds of devices, and also just gives them a lot of education about the various treatments that are out there, the pros and the cons, and allows them to connect with other people out there who have their same condition. So it's a very valuable website for a lot of my patients. Now there's a hyperhidrosis scale. Now this is related to the axilla, the armpits, but this certainly can be extrapolated to the feet. So my underarm sweating or my foot sweating is never noticeable and never interferes with daily activities, all the way up to intolerable and always interferes with activity. So most, again, patients that are coming to me, they're at 3 or 4, certainly with their feet. So I wrote a paper about this years ago in JATMA, and this was, again, before I was using preserved saline and before I was using lidocaine to reconstitute. So you'll see pictures of non-preserved saline. Again, this is just how I was taught. Things have changed, things evolve over time. Thankfully, we learn what we don't have to do anymore. So when I get that bottle of botulinum toxin A, I will reconstitute it with 4 mLs, again, depending on what solution I want to do. So that 4 ml will basically translate to 2.5 units per 0.1 ml. And I'm injecting maybe not even close to 0.1 in each spot, which I'll show you. So that's how I'm reconstituting it for this. For the other things I'm going to be talking about, you don't use 4 mLs, okay? So what's really my favorite part, I know it's really dorky, my favorite part is when you inject the solution you're reconstituting the botulinum toxin bottle with, and it's a vacuum, so you don't have to do much. You just poke the plunger and it just goes in. It's just one of the highlights of my life, which I guess doesn't say much about my life, but it is always exciting. That said, once I have that needle in there, I can use that to extrapolate the liquid, and I usually use an insulin syringe. So I use a 1 cc insulin syringe, or I use a 31 or 32 gauge, depending on what I have available. So there I am, just getting it out. Now, what I'm going to do next is do the Miner's iodine starch test. So I have my betadine ready, and I have my cornstarch. And what I do is I apply the betadine first to both feet, and then I just sprinkle it with cornstarch, and the reaction between those two materials creates the areas of highest hyperhidrosis. Now, what you're seeing is a patient that I have injected for hyperhidrosis several times, so the areas are not as concentrated as someone who I'm doing for the first time. Their whole foot just turns purple. So the areas that turn purple are the areas of greatest concentration of the active sweat glands. And so this usually happens immediately, but classically in the literature, we say to wait 10 to 15 minutes, but I never have to do that. So then what I'm going to do is I use a template, but you don't have to, and I use a skin marker and mark the areas that I'm going to inject. Now, one of the things that I've learned over the years is I never inject through the marker. It has the potential to tattoo, and even though most people aren't going to see the bottom of their feet, people don't want little purple dots tattooed on their feet permanently, so I go right underneath the dot. And it spreads out. So botulinum toxin in general and the various different exotoxins have all different degrees of diffusion. So I know that this is going to diffuse that much, and I don't have to be, again, that particularly close to each other. The dots don't have to be particularly close to each other. So again, I'm going very superficial because keep in mind, where am I injecting for hyperhidrosis? I'm injecting into the dermis. That's where the sweat glands begin. That's what I want to target. So I'm only going in about a depth of 2 to 3 millimeters. As I am injecting, I get what's called a bleb. And that's something that we kind of look just for a little bit of liquid to leak out. That I know I have satisfied and put enough fluid in there, and I don't go any further. So I'm looking for that bleb. And then I clean the patient off. So ultimately, with hyperhidrosis and doing this procedure, I know that in about a week, it's going to get to the peak of where it's going to be. And it will last anywhere from 3 months to 4 months. I've had patients that I've injected for years that come either every 6 months or once a year. So it really depends on the patient and how they react to it. But again, it's not something that overnight they're going to see a dramatic difference. It takes about a week or so for these changes to really take place. Just like if you had botulinum toxin A injected into your facial muscles, it takes about a week or so to get the effect that you want. Now, what about for plantar fasciitis? So there was a meta-analysis of 14 controlled studies, randomized controlled studies. The 537 people had 271 patients in the botulinum toxin group. And the main data was just to see the change to the visual analog scale. And indeed, that is what happened. Now, where are you injecting for plantar fascia? You're actually injecting into the fascia. You're not injecting into the muscles. You're not injecting into anywhere else. So it's just intrafascial. So the thing is as I mentioned before, botulinum toxin stops the release of acetylcholine as well as substance P. So it's the block of substance P that's really happening here. Now, what they also did was they looked at botulinum toxin versus PRP injections for plantar fasciitis, and they followed them for a year. Now, what they found was that the patients who had botulinum toxin A, in this case, injected had a faster pain reduction, but PRP did better in the long term. So ultimately, they both had success, but the botulinum toxin worked a little bit faster, which makes sense to me just knowing the physiology of what's happening. Now that said, in both groups, the plantar fascial thickness did decrease. So again, it's a win-win situation in theory for both. So the way that you can perform this procedure is you're going to reconstitute it differently than what I said for hyperhidrosis. Again, 4 mLs for hyperhidrosis, it's 1 ml for plantar fasciitis. So you're going to use your 1 cc syringe with either one, with whatever preserved saline or non-preserved saline, whatever you prefer. You're going to take your 100 unit vial and do what I said before. They used 70 units total into 1 foot. So it's 70 units for 1 foot. And they did 0.7 into 2 divided doses. And so what they did was they did 40 units or 0.4 cc's into the area medial to the plantar fascial insertion. And then they did 30 units or 0.3 cc's into the tender area of the arch. About 1 inch anterior to the heel to the center of the arch. And they used 27 gauge needle, which 27 gauge needles are completely fine, but if you can, 30 gauge needles feel a little bit better. So again, that was just for 1 foot, 70 units. So in this case, you'd need 2 bottles if you were going to perform it for both feet if the patient had bilateral heel pain. Otherwise, they have unilateral, it's 1 bottle. Now, what about neuromas? Well, there was an open label pilot study of 17 patients, and they did 1 injection of 50 units or 0.5 cc. So again, they reconstituted the same way that they did for plantar fasciitis. And they basically did palpation as well as MRI results to help guide where they were going to do the injection. And they followed the patients for 1 month, 3 months, and saw actually that the results were better at 3 months. Now that is unusual. So again, it takes about 12 to 72 hours for botulinum toxin to physiologically get in place, and then 1 to 2 weeks for you to get to your peak area of what you need it to do. So for most people, whether you're injecting somebody's face for their muscles or even again with hyperhidrosis, I expect that 3 to 4 months they're going to need another treatment. However, with neuromas, it was different. They actually had better results at 3 months than they did at 1 month. Now, the other thing is that there were 70% of patients who responded positively to this. The 30% of patients who did not have any pain relief from their neuroma injection, and these were all patients who had already failed all the typical treatments. They'd had a corticosteroid injection, they had padding, shoe gear changes, and things like that. They couldn't find a reason why those 30% failed. BMI didn't make a difference, shoe didn't make a difference. The size of the neuroma, the thickness that they calculated on MRI, didn't make a difference. So they're really not sure exactly what happened with the 30% that didn't respond. But for the 70% who did respond, again, they were still doing well at 3 months. And with our patients with neuromas, we certainly want them to have long-term relief and hopefully, not have to go on to a surgical procedure if they don't have to. So again, the size of the neuroma had no effect on the results for the people who responded and the people who didn't respond. It didn't seem to make a difference. So a lot more research has to be done in the realm of neuromas. Now, what I haven't mentioned, and because I didn't have enough time, you can inject the gastrocnemius, you can do things for the toes. There's all different things that we can utilize neuromodulators for, but I wanted to pick the 3 things that I felt were most useful to what we do and what we deal with, because again, neuromas can be so challenging sometimes to have patients to get relief from. So again, it's working on substance P here versus the acetylcholine. So that's it for me. Thank you so much, and I will be back up for question and answer.
Just something interesting. We have done 4 clinical trials on botulinum toxin. We did 1 for bunions because the idea was if you can reduce the pull of the muscles, can you reduce the bunion and have correction? We didn't find correction, but we found pain relief. That was statistically significant, and that article's been published. But for 2 plantar fascia studies and a neuroma study, didn't work so great. We found that it wasn't so successful. But it's very interesting. Thank you. All right, Dr. Goldstein's going to come up, and all things veins and tell us what to do and how to fix the varicose vein problems.
Thank you. Okay. Hi, thanks for having me. Good afternoon. Okay, so I'm going to talk a little bit about just varicose vein treatment in general as a segue into treating the more cosmetic conditions of telangiectasias and reticular veins. I'm an interventional radiologist. My practice is predominantly arterial and venous vascular disease. I'm actually here locally in Irvine. So I don't have anything to disclose. Oh, fun fact. Any large mammal veterinarians? No, okay. So giraffes don't get varicose veins. Why is that? They've managed to evolve really thick fascial layers that enclose the deep venous system. Their capillaries are impermeable to plasma proteins, so they don't get edema. They've got really tight skin that acts as like a functional compression sleeve. They have a really prominent and very active lymphatic system, and they can control their precapillary vasoconstriction to lower their venous pressures. So these tall, majestic, graceful creatures that are on their feet 24 hours a day don't get varicose veins. The rest of us, more highly evolved mammals, not so lucky. And this is basically the grading system for the severity of the symptoms and presentations for venous disease. We're going to talk a little bit about the higher level ones for a few moments, and then we'll go back to C1, the telangiectasias. This is a really very high prevalence and high cost medical condition to treat. Worldwide, 190 million patients. In the US, 30 million estimated. It's probably more than that. I think there's 30 million in Irvine. It's about $1 billion to the healthcare industry a year for treating varicose vein symptoms, and that's not including ulcers. Ulcers are another 15 billion to healthcare costs on top of that, and that's yearly. And you can see from the left side of the slide, the right side of the slide, that the incidence of this condition yearly is twice as much as other conditions we talk a lot more about, like PAD and coronary artery disease and all those other conditions combined. The presenting symptoms can vary very widely. Generally, they're pain, discomfort, might be described as heaviness, fatigue, swelling, skin damage, we call lipodermatosclerosis, visible varices, and then at the worst cases, ulcer formation. There isn't really a logical progression from one symptom to the next like you'd think there would be, like the classification system makes it appear. Symptoms can vary really widely from one person to the next within the same family. They vary from one leg to the other. They don't really have to correspond to the ultrasound findings closely. They do progress slowly with age, and the symptoms tend to be consistent. So if you happen to be someone who gets swelling, your swelling will get worse as you get older. But the swelling doesn't always progress to any of the other symptoms, things like that. And symptoms could be exacerbated by certain activities, but the cause of it is fundamentally genetic. There's a really strong genetic predisposition to venous disease, even though there are other things that are highly associated with it. But it seems to be inherited as a dominant trait. There's about a 90% concordance in identical twin studies, and 90% inheritance if both of your parents are symptomatic with venous disease, 40% if one parent is symptomatic. Where this breaks down a little bit is that there are some patients out there, maybe 20% or so, that don't have a strong family history at all of venous insufficiency, and so probably this is just incompletely understood. There may be other genetic factors that we're not understanding. It's more prevalent in women than men. In women, it presents at its peak at an earlier age, usually in the 40s. In men, they tend to present more in the 70s. Standing or sitting long periods does exacerbate the symptoms. Pregnancy certainly exacerbates the symptoms. All of my female patients think pregnancy caused their symptoms, and I have to remind them that half of my patients are male. Obesity is certainly associated with it, a sedentary lifestyle associated with all of those things. You can have congenital absence of a valve, and that can lead to symptoms, and sometimes this is precipitated by a deep venous thrombus we call the post-thrombotic syndrome. I'll talk about it a little bit later. These things exacerbate the symptoms, but they're not the cause. In our practice, we try to manage this with a very comprehensive treatment plan. So this starts with our evaluation and history and a detailed ultrasound. We do these in the office. We want to map all the sources of reflux. including the incompetent perforators, and there could be many of those, all the large clusters of varices and where they're being fed from. We start the patient right away on therapeutic compression, and I tell the patients, you're going to use these stockings at all times when you're upright. So from the minute you wake up in the morning till you go to bed at night and put your feet up, 7 days a week, you need to have these stockings on. And I look them in the eye and I really tell them that, this is your medicine. If you stop taking the medicine, your problem is going to get worse. And I try to get them to realize how important it is to wear the stockings. And if you do that, I promise you, you're still talking to a wall. Absolutely nobody's going to wear their stockings. And on top of the compression stockings, we get the patient into a lymphatic intermittent compression device. That takes a little bit of time to run through insurance, so usually that comes about a month or so after our initial consultation. But we use that for phlebial lymphedema, which is a lymphedema, but it's secondary to venous insufficiency. I instruct the patients to use that at bedtime when they take their stockings off, and try to get into the habit of stockings all day, pump at night. With your ultrasound exam, you want to interrogate the deep system as well. Any history of a chronic DVT, I don't trust the ultrasound. I think that ultrasound is limited in identifying a chronic old DVT. I'll show you an example. So I consider doing venography on some of these patients if they're going to require treatment. We want to also consider imaging the central venous system, looking for compression conditions like May-Thurner and Nutcracker, pelvic venous congestion syndrome. And for that, I typically will default to an MR venogram. If it's done well, it can be very highly diagnostic, and then from there, maybe venography and intravascular ultrasound to make the diagnosis. When you do your treatment plan, I want to treat from the inside out. I want to start with the central veins, also the deep veins if they require treatment, and then start ablating the saphenous veins, move on to ablating the perforator veins, and then treat the residual clusters of varices and remnants of the saphenous system. After that's all done, if there's no more sources of reflux and the patient's had a couple of months to recover to allow for natural regression of some of the cosmetic findings, then if the patient is interested, I will offer cosmetic treatment. So here's an example. I have a couple of clinical examples, and this is a special case to me because this patient works for me. So she was a new hire on our marketing team, and she's out in the field, and she's explaining some of these services to our referring doctors, and she comes to me and says, I think I might need this. I have these symptoms. So we did an MRI. She had lower back pain, pelvic pain, dyspareunia, venous insufficiency, 25-year-old girl. She's really symptomatic, and she'd been seeing doctors for years, and nobody was treating her. And on the MRI, it looked exactly like that picture on the left, where you see kind of like a white band across the left common iliac vein. If you're not familiar with angiography, basically I've got a catheter in the left common iliac vein, which is on your right, and that's a sheath that's large, and then through that is a smaller catheter that goes up and over to the other side. I'm injecting both of those catheters at the same time so I can get that nice venogram. And you can see that white band, which we refer to as a thumbprint. That's the right common iliac artery compressing and pinching off the left common iliac vein. And you can see the enlargement of the left common iliac vein compared to the right. You see those veins in the lower pelvis, that's reflux in the internal iliac vein and varices in the pelvis as the blood flow is trying to collateralize and get to the other side and get around this obstruction. And this was very simply treated by placing a stent on the left side. It's a little hard to see on that image, but the stent resolves the occlusion, resolved the reflux in the internal iliac veins, resolved the pelvic varices. Believe it or not, her subsequent lower extremity ultrasound was also normal, and she's been doing well for about 4 years since then. This is a more recent patient who also presented with similar symptoms of back pain and pelvic pain, lower extremity venous insufficiency. On her study, though, she has another condition called Nutcracker syndrome. This is where the left renal vein is pinched off by the superior mesenteric vein as it comes off the aorta. And the renal vein is spanning over the front of the aorta to get to the vena cava. All the renal blood flow is being shunted down into the gonadal vein, and that middle picture is the large cluster of pelvic varices that are being fed by that reflux. Again, pretty simply treated by placing a stent in the left renal vein, normalizing renal venous outflow, and you no longer see that reflux in the left gonadal vein. That happened immediately. She's coming back in a little while. I want to see if maybe I might still have to treat those ovarian veins, but if her symptoms get better, I'm going to leave that And this is a patient with a chronic DVT. This case is about 6 years old now. Here's why I don't like ultrasound for chronic DVT. When you've got an acute DVT, you've got this big vein with this nice big juicy clot in it, and it's very easy to make that diagnosis. But years later, the clot's gonna regress and change in character. It's gonna get smaller. It's gonna get harder to see on ultrasound. The vein doesn't reopen. The vein is actually destroyed. It's not like your clot's gonna go away and you're gonna have a nice healthy vein with normal valves again. So the whole vein shrinks and gets smaller. You get collateral flow around that obstruction, and the collateral flow lives kind of right around where that vein used to be. So on ultrasound, what the technologist is usually seeing is a partially recanalized vein or maybe some residual thrombus that's not completely resolved, but it's definitely getting better. None of those things are true. The vein is completely destroyed and you're just seeing collateral flow around it, which never gets the patient back to fully normal venous outflow. So this was a patient who was really symptomatic, also had varices and needed to be treated. And so I spent a lot of time on this. This is a long case. And I was able to get through the native lumen of the popliteal vein and the distal superficial femoral vein, stent that open and restore normal flow. He actually felt so much better, he never did get his varicose veins treated. He's still doing fine 6 years later. So as part of this comprehensive treatment plan, when do we want to look higher? We're realizing that most lower extremity ultrasounds are going to miss any venous disease that doesn't live in the legs. It's not cost effective to get an MRI or a venogram on every single patient who presents with venous insufficiency, but there's basically 5 classes of patients that I always want to investigate a little further. Any patient, obviously, with symptoms of pain or varices in the abdomen and pelvis, in the perineum, in the genitalia. Any patient with a history of a DVT. Any patient with an abnormal ultrasound finding in the deep venous system, which could be deep venous reflux, it could be chronic occlusion. Any patient with a drastic disparity in symptoms from one leg to the other. There's a little bit of variance from one leg to the other in most patients with venous insufficiency, but drastic ultrasound findings, drastic symptoms in one leg and normal in the other leg, that's not the typical inheritance pattern of general run-of-the-mill chronic venous insufficiency. And then if I've treated the patient or they've had treatment elsewhere and their symptoms are coming back repeatedly, they definitely need to be investigated because you're probably treating against an obstruction and you're never going to get good results unless you resolve that obstruction. Being persistent is the key to getting good outcomes and getting resolution of the symptoms. You need to resolve all of the causes of venous hypertension. Any point of obstruction, any point of reflux, it has to be addressed. And I tell patients, this might take a long time. This might require lots of procedures. If you put out half a house fire, you still have a house fire. So it's a chronic problem. It requires maintenance over a long period of time. Once patients are stable, I at least bring them back once a year for a follow-up ultrasound. Patients are told to call me if they have any recurrence of symptoms at all, and we reinvestigate. The most likely source of recurrence is the innumerable incompetent perforator veins that live in both legs. There's probably about 200 in each leg, and you can't treat them, you can't see them until they enlarge and become symptomatic, but they all probably have abnormal valves. Incompetent veins may not be treatable until they enlarge and begin to cause symptoms. Sorry if I repeat myself. This is an example of treatment of an incompetent perforator in the foot. This is a patient with a toe ulcer in the hallux, and this really large perforator vein is right between the first and second metatarsal bones. And to give you an idea of scale, that is not a small needle. That's about a 14-gauge cannula. This vein was gigantic. But you got to look everywhere because you won't find the veins unless you look. So now we can talk about spider veins, reticular veins, and telangiectasia. Telangiectasias are basically visible superficial skin vessels. They enlarge under abnormal pressure. They generally range in size from up to 1 millimeter. They can be any part of the capillary bed. It can be a venule, the capillary itself, or the arteriole. Telangiectasias with more arterial component, they're going to be redder. They might be a little deeper. They won't be so exophytic to the skin surface. The venous ones are going to be obviously darker blue or purple. They're going to bulge out a little bit more at the surface of the skin. They have different patterns. They can be simple and linear, arborizing or branching like a tree. Spider veins, which appear in more of a pinwheel type of pattern, and papular, which would be just kind of small focal round lesions. Reticular veins are generally the veins that feed these telangiectasias. They're a little deeper and a little larger. They're 1 to 4 millimeters in size. And then larger than that, we consider varicose veins. They're 4 millimeters and up. Causes, obviously, chronic venous insufficiency, but there are other conditions. There's congenital syndromes that give you vascular skin lesions, neuroangiopathies, collagen vascular diseases as well. We can treat this with sclerotherapy. Sclerotherapy literally dates back to the invention of the syringe. This goes back to the early 1800s and probably earlier than that. The mechanism of action of sclerotherapy is to damage the endothelial lining. We want to expose the subendothelial collagen, which starts platelet aggregation, spasm, the intrinsic pathway of the clotting cascade is activated, thrombosis starts, and then ultimately fibrosis of the vessel. The goal is to accomplish this with a minimum amount of thrombus formation with maximal thrombus adhesion to the vessel wall, which prevents recanalization, prevents embolization. There's plenty of agents to choose from. They basically are classified into 3 groups: osmotic agents, chemical irritants, and detergents. The osmotic agents, they basically dehydrate the endothelial cells to disrupt the cell wall. They're liquid agents, things like hypertonic saline. They rapidly dilute in the blood, so they have very little systemic effect, but they can be very painful when injected locally. They do cause much more tissue damage if they happen to infiltrate. Hypertonic saline is one example. Sclerodex is a mixture of hypertonic saline and dextrose as well. Chemical irritants, not really used for this very commonly. There is an IR doc in the Midwest who does a lot of vascular malformations using things like alcohol. Alcohol phenol, polyiodinated, I can't even pronounce it, iodinated iodine. Did I make it? No, I didn't. And glycerin or combinations of glycerin, lidocaine, and epinephrine. Those are the chemical irritants. We don't use those very commonly. Detergents, the way they work, it's essentially soap. It's going to form a mycel. These chemicals are both hydrophilic and hydrophobic, so they're able to denature proteins and solubilize those things into liquid. That destroys the cell wall within a minute or two of contact. You can titrate the concentration very easily for vessel size. They can be administered as a foam, which we'll talk about a little more. The prime example over the last maybe 10 to 15 years is polydocanol. Prior to that, sodium tetradecyl sulfate and sodium morioate and ethanolamine oleate. We don't use those very commonly anymore. You can have combination agents as well, such as polydocanol mixed with glucose, mixed with sterile water in equal parts. What that does is it adds a little more viscosity to the agent so that it injects a little slower, it lingers in the vessel a little bit longer. So microfoam sclerotherapy. When you mix the detergent with air, you're going to get soap suds. And so the air in the drug creates a vapor lock effect in a blood vessel. So this increases the dwell time. The foam actually displaces blood from the blood vessel. It doesn't mix with the blood. So you get increased efficiency because you end up with a smaller amount of drug to get a higher concentration of it in contact with the vessel wall for longer. It is visible on ultrasound. Air shows up as bright white if you're using ultrasound guidance. It's easy to make. There's a technique called the modified Tessari technique where you basically take a syringe with a little bit of the liquid polydocanol and a syringe with air, and you swish them back and forth with something connecting them like a 3-way stopcock or something like that. The foam is generally pretty stable. You can always re-agitate it if you're seeing it start to break down before your injection. I would caution not to mix it too early before you're going to use it because it can chemically interact with the rubber stopper and the silicone coating in a syringe, and the syringe starts to get a little sticky and hard to use. Polydocanol is the agent we use most commonly. It was FDA approved in 2010. In the US, it's available in 0.5% and 1% concentrations, 2 milliliter ampules. Of note, 5% alcohol is added to the polydocanol in the manufacturing process, which acts as an emulsifier and keeps it from foaming up while it's being manufactured and packaged. So just keep that in mind that you are injecting a little bit of alcohol in there. It's got a 4-hour half-life in humans, 89% eliminated in 12 hours. It's generally eliminated through the respiratory system, but also renal and GI. It doesn't accumulate, so you can do multiple treatments over time, and there's no cumulative effects. It does not cross the blood-brain barrier. It does cross the placental barrier. It hasn't been demonstrated that it causes any harm to a fetus, but it's generally recommended not to use it. It's painless. It is actually a local anesthetic. It doesn't induce ulceration, even if it infiltrates out of the blood vessel, as long as it's a concentration less than 1%. allergic reactions are extremely rare, and it causes much less pigmentation at the local site of injection than other agents. You can adjust the concentration for varying sizes of blood vessels. Generally, I use somewhere between 0.5% and 1%. I'll buy it at 1%, and I might take the 2 cc's and add a cc of saline to it, so it's probably about 66%. And then from there, I've got 3 cc's, and I'll add about 6 cc's of air and swish that around, and I'll have, roughly about 10 or 12 cc's of foam to use. Smallest spider veins, you might want to consider sticking with a liquid agent because the foam can be a little expansile and it can cause rupture of a really tiny vein, keeping in mind these things are only a few cells thick. Maximum dose of the polydocanol is 2 milligrams per kilogram per day. With a 3% injection, that's 2 milliliters at any injection site, and 6 milliliters per total treatment session. 1%, I'll generally go up to about 10 milliliters. Keep in mind the vein that you are injecting, the volume of that vein is dependent on the square of the radius, although I do not know how to type a square on my computer. So the same volume of foam is going to travel a much shorter distance in a larger vein, and this chart kind of demonstrates, in the largest vessel there, most of the foam is just going to kind of gravitate towards the more superior wall and probably not fill the entire vein. So you're going to need to do some kind of compression maneuvers to facilitate a good closure. And then when you get down to the smallest veins, a small amount of the drug is going to travel a long way in those small veins, because of that logarithmic relationship. Technique of injection. There's a lot of variations on this, but generally with the advent of foam sclerotherapy, patients can lay supine throughout the procedure, which makes it comfortable and easy. They don't have to be standing. You don't have to have the leg super elevated, although some people like to empty the vein before injecting the sclerotherapy, so you might want to have your leg elevated a little bit. Generally, we mix it in a 1:4 liquid to gas ratio. You can use carbon dioxide gas, and there's a product that's available on the market that's pre-mixed with carbon dioxide gas. Carbon dioxide does reabsorb into the bloodstream very quickly, so I think mixing it with air, it does linger in the blood vessel a little bit longer. I've been doing this for 15 years and haven't had any issues with that. Again, foam displaces the blood. It fills the lumen largely with air. So the dilute drug, it lives in the wall of the gas bubbles, and the gas bubbles are in contact with the vein wall. So it concentrates at the site of activity, and then you're not filling the entire volume of the vein with drug. You're filling it mostly with air, so you can get away with using a lot less drug. The foam does induce vasospasm, which further limits washout of the sclerosant and increases contact with the vessel wall. If you're doing this with ultrasound guidance, you can see that happening almost immediately. So you inject, you see the foam fill the vessel, you see the vessel kind of get really small, and then the foam just kind of stays there. You check it a couple minutes later and the foam's still there, it hasn't washed out. So a little more on technique. Generally, we inject with a 30 gauge needle. You can go smaller. We bend the needle at a shallow angle. We use a small syringe, 1, 2, or 3 cc. Using a butterfly is really helpful. That little length of tubing helps to separate the needle from the syringe. There's always going to be a little vibration of the syringe when you're trying to inject the plunger, and that's going to jostle the needle in this tiny little vein. So having that little bit of tubing to separate the two is really helpful. Inject slowly under low pressure. Observe the skin for discoloration, for signs of infiltration. Stop injecting if you see that. To cannulate the vein, you can use transillumination. You may want to maybe get a pair of loupes to help magnify it a little bit. Alcohol on the skin helps to minimize the light refraction, and it makes it a little easier to get the needle in. You want to confirm intraluminal venous placement prior to injection. You want to try to avoid arterial injection. Immediately after injection, once you're done, you want to compress, and you want to get the patient into a garment of about 30 to 40 millimeters of mercury. You want to get them ambulating right away. We usually do like a deep calf massage. We have them pump the foot and elevate the leg for a couple of minutes, and we check with ultrasound when we're doing these procedures to make sure that we don't see any foam in the deep venous system. And then you might feel the need to use a tourniquet to cannulate. Make sure you're not injecting with the tourniquet still up. You will force the foam to go where you don't want it to go. Some adverse outcomes that can occur. Hyperpigmentation is one of the main ones. This can be caused by melanin, hemosiderin, iron. It can be treated with topical laser. It can be treated with retinoic acid. It's probably best to try to avoid it if you can. Coagula, this is like a liquid or liquefied clot that remains trapped in an occluded telangiectasia or spider vein or reticular vein. It can be really painful and kind of unsightly. So usually after a couple of weeks, if it's still there, what you might want to do is just kind of prick the surface of the vein with a small needle and slowly express the liquid clot out of there. And you might have to repeat this. Urticaria is kind of a normal reaction. It's just redness. You can treat it with a topical steroid. Usually if you do nothing, it'll go away by itself over time. Ulceration, generally related to extravasation of the sclerosant or arteriolar or lymphatic injection. They tend to be small. They tend to heal over time. They might leave a little residual scar. Usually makes the patient unhappy. Treat any wound like any other wound. Keep it clean. Change dressings, antibiotic ointment. Watch for signs of infection. DVT and pulmonary embolism, fortunately very rare, but if you over-inject and if you're, happen to inject into a perforator and it gets into the deep system, you don't take maneuvers to try to prevent that, then it's possible you can get that. Patients who are hypercoagulable, high volume injections, injecting pedal veins is slightly higher risk than injecting leg veins. If you over-compress with your compression garment, or patients using estrogen, which predisposes to being hypercoagulable. Recurrence is one of the more common adverse outcomes. I wouldn't consider it to be really an adverse outcome, except in the eyes of the patient, they might. Because of recurrence, I try to tell patients that they really do need to be kind of on a maintenance plan. And I talk to them like, I try to analogize it as this is the way we take care of our teeth, right? You go to the dentist, you get a cavity filled, you're not done, you're not cured of cavities for the rest of your life. You still go back every year, you get a checkup, you get another cavity, you get it treated. You have to treat your veins the same way. The top line there is what happens with no treatment. It just kind of steadily gets worse as we get older. Is it black? Yeah, the black line is after a single treatment, so you might see improvement immediately after the treatment, but then if you leave it alone, the condition's going to progress again over time. And so, if you tell the patient that, come back and see me every time you start to see recurrence and we'll get it treated, you can keep them maintained at a level where they'll probably be happy with the cosmetic result. Contraindications. A right to left cardiac shunt, like a patent foramen ovale, probably want to avoid those. Anybody with an acute DVT or superficial venous thrombus, it's an absolute contraindication to treatment with sclerotherapy. If they have a history of DVT, it's a relative contraindication. I would investigate them really thoroughly before proceeding with treatment. Any hypercoagulable condition. Patients with migraines, you can precipitate migraine as a side effect. It might manifest as visual disturbance. Pregnancy, contraindication. If they're unable to ambulate, again, another predisposition for developing a DVT we want to avoid. Obviously, if they have allergy to the medication that's known, patients on estrogen hormone replacement or tamoxifen, hypercoagulable conditions associated with that. Disulfiram, remember, there's alcohol in the polydocanol. You can actually precipitate an alcohol disulfiram reaction. This is used to treat patients with alcohol dependency. Generally, results of foam sclerotherapy are really good. Over about 90% of telangiectasias, reticular veins, small varices will resolve with injection. And major adverse outcomes are overall extremely rare. Minor adverse outcomes, we typically see in about a less than 5% range, and we can consider many of them to be treatable and almost expected sequelae of sclerotherapy if it's managed properly. Reimbursement, I know this was a topic of interest. This is not covered by Medicare or insurances that follow Medicare. It's essentially a cash pay. You got to kind of feel out what's available in your market. There's a lot of competition out there. Establish pricing based on your regional location, the extent of disease that you're treating at any given time, how much time you spend on it, how much it costs to run your office for that period of time, what kind of margins you see on other procedures that you do. Try to keep it comparable and have a list of pricing available for patients at the consultation so that there's no surprises when they show up. Okay, so that's sclerotherapy. And then I'm going to talk about laser treatment for varicose veins. I'm going way out over my skis here. I don't do an awful lot of this. Advantages of laser treatment over sclerotherapy are that it does appeal to some patients as a state-of-the-art, more futuristic type of treatment. It's not associated with long-term or systemic side effects. Hyperpigmentation is still a risk, but it's less than half of the risk of hyperpigmentation from sclerotherapy. There's much less red blood cell extravasation and hemosiderin deposition. Telangiectatic matting, which is a side effect of sclerotherapy caused by kind of an exuberant type of angiogenesis. We don't see that with laser. In fact, we can use laser to treat telangiectatic matting that you might see with sclerotherapy. And you avoid the use of needles and bleeding and infiltration and all that. So a little bit about the physics of laser and why this works. Most medical lasers are using wavelengths that are within the visible light spectrum and maybe a little bit into the infrared spectrum, but it's not ionizing radiation. Light's absorbed by the chromophore, which is the target, and the wavelength of the light is tuned to the peak absorption of the target that you're trying to hit. Hemoglobin, for example, oxyhemoglobin has a slightly different peak than deoxyhemoglobin, so you want to kind of fine-tune it for the deoxyhemoglobin, which is in the venous system. Once the light is absorbed by the chromophore, the light energy is converted to heat, and the heat is what causes the damage to the vessel wall. It causes coagulation, and you want to try to do this without generating so much heat that it starts to cause damage to the surrounding tissues. Like I said, the wavelengths are specific to the absorption of the target. The most common wavelengths in clinical practice nowadays is generally 532 nanometers, 1064 nanometers. These are the wavelengths that are found using the NID-YAG crystal based units. Don't ask me what NID-YAG stands for, but it's just a particular type of crystal. The way light interacts with tissue, there's 4 different things that happen. One is it might reflect right off. The other is it might transmit all the way through. It might scatter within the tissue. What we really want to happen is we want it to be absorbed at the target and to generate heat in that location. So we have parameters that we adjust for to try to optimize the settings for that to occur. We choose the wavelength to optimize for the target, the vessel size, and the depth as well. The fluence is a term for the energy that's delivered to the target area, and that's expressed as joules per centimeter squared. Higher fluence is going to lead to more efficacy of the treatment, but also risk of more thermal injury. So you have to kind of strike a balance where you're getting good treatment, but you're not causing too much damage. The spot size of the laser that you're going to use, that's going to determine the depth of penetration. This part's a little counterintuitive, but a smaller spot size where the energy of the beam is more dense within that spot size, it actually penetrates less through the skin than a larger spot size where the energy density is lower. And then the light is pulsed so that the duration of the heat transfer has kind of breaks in between to allow for some cooling, which limits the accumulation of heat and spreading of the heat zone. There's a little graphical representation of the small spot size and the large spot size. And I didn't find a really good explanation for this in anything I've read so far, but I think it has to do with scatter. Even though there's more energy in the smaller spot size, I think scattering is going to occur and limit the amount of energy that makes it to the deeper tissues. But in a larger spot size, if the scattering is constant, you're going to get more penetration. I may be wrong about that. Treatment examples, so when we have a more superficial target like these fine telangiectasias, we want to choose a shorter wavelength. We want to choose a small spot size. We want to choose a shorter pulse length, and because there's more energy in the beam in a smaller spot size, we want to reduce the energy that's delivered because we don't need that much. Less cooling is going to be needed if we use less energy. The total fluence is going to be in the range of about 10 to 20 joules per centimeter squared for treating something like this. Be mindful, though, that superficial treatment, the light beam is going to interact with melanocytes, and it can cause hypopigmentation, particularly in darker-skinned individuals. Deeper veins, and note kind of off to the right side is the reticular vein feeding that network of spider veins. We want to use a longer wavelength for deeper penetration, a larger spot size for deeper penetration. The pulse is going to need to be longer because there's less energy in the spot size. Because we want to increase the energy. The vessels are larger. We're going to need a little more cooling with that increased energy. We're going to probably use affluence of 70 to 150 joules per centimeter squared. And we don't necessarily have to worry about the melanocytes anymore because they don't live down there. So, did I hit the button? No. Okay, so you want to make sure that you've got full skin contact with your device before you deliver the energy. You can apply a thin gel layer for skin protection, make sure there's no air bubbles in it. Use a very light pressure when you're in contact with the skin to avoid compression of the target vessel. Generally, spot sizes within 10 to 12 millimeters. You can overlap the treatment sites by maybe 10 to 20%, but if you overlap too much, you're really kind of double treating and you're increasing the risk of thermal injury. Observe for skin damage while you're treating, blanching, gray coloration, blistering. Stop if you see that. Observe for the treatment endpoint, which would be vessel color change or disappearance of the vessel, vascular constriction, erythema or purpura. Those are normal reactions after laser treatment. You can apply a second pulse if you allow time for complete cooling, but generally we want to treat once and then have the patient recover a few weeks, come back for an additional treatment if that's necessary. Post-treatment, apply a cold compress. If you do see blistering, treat it as a wound. Retreat after 4 to 6 weeks of recovery. The patient should avoid contact with the sun, using a broad spectrum sunscreen, avoid heat like saunas or hot tubs, avoid skin irritants for several days. You can do combination therapy of laser treatment immediately followed by sclerotherapy within the same session. There's an advantage there of being able to use less energy with the laser and less drug with the sclerotherapy and get a good result. This is not something that we do, but it's a possibility. Some contraindications for this, again, pregnancy, I'm not sure why, skin cancer or any questionable lesion on the skin, I would avoid. If the patient has a fresh tan, even a fake tan, a tattoo in the region, metal or electronic implant in the region, I wouldn't treat. An open wound or infection, don't treat. If they've been taking Accutane within the last 6 months, don't treat, stop that drug for up to 6 months, at least 6 months. If the patient's anticoagulated, you can get a lot more bruising or vascular rupture, so I would get them off anticoagulation first. And then use caution in patients that develop keloid, who have dark skin types, or vitiligo. Avoiding problems in general, you want to take good pre-treatment photographs. Shave the area if there's coarse hair, but avoid using any topical agents on the skin prior to treatment. Do a test spot. Test the treatment, see how the skin and the vessel react before moving on and completing the rest of your treatment. That's really important. Don't treat large varices with laser, you won't get good results. And then make sure you're consenting and educating the patient thoroughly so they know what to expect in terms of how long it's going to take for this to ultimately clear and resolve. Choosing equipment for your practice. There's a number of systems that are available, and most of them are versatile enough that they offer multiple wavelengths. You can adjust pulse duration, the total fluence. You can apply cooling to, and you can treat nearly any form of telangiectasia. It still requires a lot of skill in order to do this properly and to avoid thermal injury and get good results. The unit that we bought, I'm pretty sure we bought it used and just got a really good price on it. So you just have to, negotiate with your vendors and see, how are you going to recoup the expense of the laser, within your practice. Again, reimbursement, like with cosmetic sclerotherapy, it's largely going to be cash pay. Pricing is going to be dependent on time, the surface area treated, recouping the cost of your equipment, and what kind of margins you like to see in general for procedures done at your practice. So in summary, both sclerotherapy and laser treatment are effective for the cosmetic treatment of telangiectasias and reticular veins. There's some advantages to sclerotherapy, such as low cost of goods, improved safety and efficacy of foam technique, and the length of experience that we have, which goes back decades. There's some advantages to laser, which is reduced local side effects and elimination of systemic side effects, avoidance of needles, and meeting demands of some patients. It is a more expensive option. Both require experience and long-term maintenance of treatment for optimal results. And I think that these should be considered as part of a more comprehensive total treatment plan to address all the causes and symptoms of venous hypertension. And that's all I got. Thank you.
All right, last but not least, we're gonna get Ebony to come up and give her talk. Ebony, my feet are killing me. And afterwards, we'll do a question and answer, okay? Yeah.
Alrighty. This is the clicker right here. Okay. Hi, everybody. Nice to see everyone. My lecture is more cosmetic. How exciting. I'm not going to show you pictures of gross feet. But essentially, my lecture is about options for dystrophic nails. We all see fungal nails, and a lot of times the only thing we can do is debride them and prescribe medicine, oral or topical, and wait and see what happens. But we live in a state where everyone's on the beach every day throughout the year, and we need options for people to feel more confident. So this is something that I have implemented in my practice. It is a cosmetic procedure, so it's not covered by insurance. So this is something that is purely cash-based that people love, that has turned out to be really good for my practice. So just to get through, okay. There we go. So I do not have any relevant disclosures, no funding or support for the preparation or delivery of this presentation. So this is purely just because I want you guys to know. So basically it is a nail restoration kit. It's a composite resin material. Sometimes people are coming to the clinic having had fungal nails, gone to a pedicurist, and they've applied an acrylic nail. And the acrylic nail has caused their nail to be even more fungal. And so the question is, okay, so how do I make my nail pretty but still also treat it with the fungus? So this nail restoration kit is essentially a resin bonding material. It's something that dentists use a lot in their procedures. It's kind of like plastic, if you think of it like that. And what it does, it's non-porous. A acrylic nail is very porous, which means that anytime you're in the shower, water can seep underneath the nail, therefore making a huge breeding ground for more fungus to occur. So with this resin bonding material, you're able to apply it to the nail and actually have it not be porous. And so therefore the new growing nail, we can actually try to treat that while you have a prettier looking nail. So you can, well, in the kit, it does have antifungal properties within the kit. So you are actually getting a little bit of treatment, but it's not an actual treatment for fungal nails. So you have to make that clear to your patients. This is not a treatment for fungal nails. This is something that can assist you in looking nice while you treat your fungal nails. So who is the nail restoration kit for? People who have fungal nails. Cracked nails are also a thing that I can use it for. I have patients all the time who may have had an injury and the nail has somehow grown back with a line in it. Sometimes these people are very much so putting a microscope on their nails and they're just like, something's just not right. And every time it gets to a certain length, it starts to cut off or something goes wrong with the nail. This is an option for those patients as well. Or patients who have had injuries in the past, you've treated them with fungus before, it's not gonna work because the nail's dystrophic. There's no evidence of any type of fungus in the nail, but they do have something there that grows, but it's just not normal. So that's for your younger patients who might just have a little bit of a self-consciousness about their nails, so they sometimes can get that. I get a lot of young ladies, especially with dystrophic nails, with proms, weddings, things of that nature, that really would benefit from this. More importantly, who should not use the nail restoration kit are people who have peripheral vascular disease, arterial insufficiency, people with peripheral neuropathy. or anything suspicious with a lesion, like you don't want to just cover it up and let it go, or people with ingrown nails, because that could cause an infection. So you also want to be careful with patients who are pregnant or nursing, because the feet tend to swell, and they also might be allergic to the ingredients of the nail restoration kit. So just be careful about those types of patients. But otherwise, this is a very low-risk type of cosmetic procedure that can be done quickly in the office. So people who can't get it are people who have no nail. This does not, you can't just paste it to the skin. It has to have at least 15% of the natural nail that's present, because the resin bonding agent has to attach to your nail and then to itself. People have asked, and I have, tried just to appease their minds. It does not work on skin. So if you have that idea, like I'll just, try it on a patient who's asking for it, it doesn't work. Take it from me. So anyways, so you have to make sure that a portion of the nail is present. And like I said before, people who have special occasions, weddings, proms, parties, or even just summer, or if you live in the state of California, or maybe even Florida, this is something that you can apply to the nail. So the nail restoration kit is something that you have to apply with steps. It's not just something that you paste on the person's 15% nail. This is a agent that comes in a tube. So I'll go over the steps on how to apply it in a little bit. But essentially, the resin bonding agent isn't it's not rigid like an acrylic nail. An acrylic nail will, it's very rigid, and it will, when it's moved, it can create this micro trauma to the nail. So every time the acrylic moves, it creates a little bit of trauma. And then, like I said before, it's porous. So you're creating this really not optimal environment for the patient to have a chance to even try to grow a better nail. The resin bonding agent is flexible and it's durable, and it's designed specifically for this purpose. We walk on our feet every day. We know just how much wear and tear the feet take. So this material is designed for you to do all of your activities. I have patients who do Pilates or yoga, or are runners even, who continuously take a beating in the shoes every day, that still have longevity when it comes to after this is applied. Also, you have to be cognizant of all the harsh chemicals that the acrylic nails will provide for you. This resin bonding agent and the nail restoration kit does not have all those harsh chemicals. In fact, it does have some antifungal properties with the application, so this is right up our alley when we're trying to actually medically help somebody when it comes to their fungus. So, with the nail restoration kit, I'm using all of the other modalities that are normally used to treat someone with a fungus. I'm getting labs, making sure their liver is okay, and then we can start an oral medication regime. But I am also doing topical medications. The topical medication will not infiltrate the resin bonding agent because it is not porous. So what I tell people all the time, you put the topical medication where the new growing nail is, because that's what we're treating. In fact, we're treating the new growing nail. So they can use the topical medication while the resin bonding agent is there, but just right at the cuticle there. People have asked about laser also. If you do have a laser kit there, you can do it prior to applying the resin bonding agent, but not during. It's not going to penetrate. It's not going to do anything. So sometimes people want to hit at every angle. So they're doing the laser, they're doing the topical, they're doing the oral medication, and then they wanted a pretty nail. So all of these options are available to you. Just you can't do the laser while the resin bonding agent is there. So how long does this last? It can give you a good 6 to 8 weeks. That could be enough time for a summer vacation. It depends on how many nails. Usually, my talk today is specifically about the hallux toenail, the big toenail. The lesser toenails may not give you 6 to 8 weeks because they're smaller. And it may not have as much nail in order for the resin bonding agent to last that long. But the longest that I've had personally is about 4 months. And the patient was really, really happy. And at that point, once you take the resin bonding agent off, you kind of see what the new nail underneath there looks like, and you can consider whether or not it's even worth it to apply it again, or if their regular nail is in fact better. So I tell always people that the first day after you apply it, no saunas, no pools, no gyms. You want to make sure that you're giving it a good, at least 8 to 12 hour period to kind of settle in. The color starts off as like a bright pink, but then it kind of neutralizes out, and so it looks like a normal colored nail. So I tell people once that color neutralizes out, you should be good to go and do everything that you want to do. If the nail is gonna fall off, it's gonna do so within the first week. I usually tell people if it does fall off, come back, we'll reapply it free of charge, no big deal. And it's usually because something got underneath it. Maybe the patient didn't wear sandals to the podiatrist appointment and they shoved their foot right in a shoe and they maybe have hyperhidrosis, I'm not sure. But sometimes it does fail, but if it does fail, it's gonna be very soon after application. So how do you apply it? It comes in a kit. It's very easy steps. Trim it like you would any other fungal nail. Smooth it out, make sure everything is really smooth. And then you have to apply the bonding agent. This is what has that antifungal property in there. The kit does come with a laser light, which does speed up the process quite a bit. So you're holding the light anywhere between 30 and 60 seconds for each of these steps. But essentially you apply the bonding agent, and then you have your first layer of the resin bonding agent. You want to apply that directly onto the native nail. I usually am doing it up to 50% of like the nail bed surface, and then after the laser, once it dries, you do a second layer of the resin bonding agent, and that attaches to the previous layer, and then you can extend it all the way up to where it looks nice, like a normal nail. It comes with like a little wooden stick where you can kind of shape the nail as well. So after that, you put the UV light on again, and then you put the sealant. It's pretty easy peasy. After you put the sealant on, you're waiting for 60 seconds, making sure everything is dry, and then I use my burr to just basically reshape it, making sure everything is pretty good. Put some alcohol on it, makes it nice and shiny, and let the patient go. This is a little bit of a before and after. Which is actually pretty good. If you take a look at some of the fungal nails, I don't have any pictures of after the nail is off, like miraculously, it's healed. But like I said, this is a cosmetic procedure that can warrant some healing of the nail with an additive treatment, oral or topical. So, briefly, we'll discuss the benefits of it to your practice. If you guys don't have an option like this, they do, it's all cash, so you can make your prices what they are. For me, I'm pricing based off of the kits, so I'm having my patients keep their kit, because obviously they have fungus for a reason. It's just kind of like, this is your kit. You bring it back to me when you want another application, but essentially I'm charging about $295 per nail, so it's a lot of return because it's like I'm only seeing these patients every 2 to 3 months. And then in addition to all of the expenses aren't that terrible. It's a one-time fee for the UV light, and I'm buying my nail restoration kits probably 5 at a time, because this is not something that I promote that I do for my practice, but it is I do have patients that are in need, and I like to have this option available to them if they need it. So there are other benefits to their website, actually. If you sign up to do these kinds of procedures, they do have a physician finder that's available. So if someone's looking for a restored nail, some podiatrists that do nail restoration, they can find you easily based off of their Google search. And it's a low-risk cosmetic solution. And you can potentially gain a patient for life, you know, their family members, everything. So if any young practitioners are in the building, this is something that I did start when I first got into practice. It's something that I do less now that I'm a little bit more established, but it is something that I still have available. I think physician finders, when it comes to cosmetic procedures like this, are definitely helpful with your marketing. So that is the conclusion of my nail restoration procedure. And if you guys have questions, I'm an open book.
All right. So I know now where to go. My nails, I'm going to Dr. Vincent, and for the fat in my stomach, I'm going to go to Dr. Sobel. All right. We have a few questions. How long do the allograft fat pad injections typically last for?
Wait, what was it? The allograft ones?
Yes.
So 1 to 3 years. So if you're using one of the exogenous products, it's roughly 1 to 3 years. Depends on how bad the atrophy is and the deformity and how active your patient is. Some of these people are like runners or very active, but anywhere from 1 to 3 years.
I think one other thing is when these products first came out, there was a lot of conversation about, you know, offloading the area, not letting people walk on it, staying off it. What are you doing for that now? Are you letting them walk on it fairly quickly, or?
So depends on which product I'm using. So if I'm using a hyaluronic acid, that's like instant plumping. Offloading, it doesn't really make a difference. If I am using one of the products that has to like incorporate into the vasculature, like one of your allograft products, then 2 weeks, because they've done some studies on that with like looking at the ultrasound and like when it actually incorporates. So those first 2 weeks are the most important.
What do you have them do the first 2 weeks?
Padding. So the
padding.
Vsat, yep, I'll have them pad, and that's why I pad it in the office. We have them take a picture with their phone, so when they go home, they know how to reapply those pads, and then we send them with pads. And depends on how big the area, sometimes post-op shoe as well as the pad.
Okay. Next question was from Dr. Mansdorf, and he says, if using a hydroxyapatite injection material, do you use it at full strength or do you dilute it? I think, are we talking about what Tracy was talking about regarding?
Yeah, you dilute it.
I think that's what he's asking about.
Yes.
He's talking about botulinum and whether you dilute it or not.
No, this is a different one, but yes,
Oh,
we dilute, yes. No.
How do you dilute it? Just so.
Great question. It's like
1 to 4.
There's like, I'd have to get back to you on that. There's
Okay.
like a chart on there. I don't have
Okay.
it memorized. Yeah, I just looked at it before.
Next question. What is your selection criteria for using hydroxyapatite versus hyaluronic acid injections? Neil, you really like the hydroxyapatite, huh?
He does.
You're into it.
Depends on where, and I have the conversation with my patients about, so sometimes they just want an instant fix, so then I would use the hyaluronic acid, or the hyaluronic acid. The other product is going to take a while for the patient to see the effect because you're, needing that collagen to build up. So if the patient needs a quick fix, that's usually when I would opt for the hyaluronic acid, or in the toes. I do like it in the toes, and there it does last longer as well versus the bottom of the foot.
Okay, and I think we had one more question, again from Neil. Thanks, Neil, for the questions. At least we have something to do up here, huh? Do you inject the neuromodulator intraneural or perineural for neuroma? And does injecting proximal to the neuroma versus into mass have any bearing on response? What a fantastic question, Neil.
That is a great question. So perineural, and you can use palpation or ultrasound to determine where you're going to inject. And certainly, you know, palpating at the area where it's uncomfortable, that would be, and all the study, again, the study, they looked at palpation and MRI.
All right, Neil, any other questions? Sorry, I don't mean.
I do want to add that the actual nail restoration kit, I was actually the first in
Can we
the
say what the
States to
name
use
of
that.
their name? We're not allowed to say the name
We're
of
not
the nail
allowed to
rest.
say the names.
Can you,
Cariflex.
can you
It's
whisper it in my
Cariflex.
ear? Because I really don't care. I'd rather, I mean,
It's Cariflex. And
Cariflex.
so
Okay, great.
recently, what we found out was I worked with a dermatologist to use it on patients with onychomatosis and retronychia. And it reduced pain and also helped with the nail growing out. But also you can use it with nail polish. And I think that's something that my patients really enjoy, that they can utilize nail polish to camouflage along with that smoothness that the restoration kit provides.
can somebody come up for the varicose vein question, even though we don't really do it, so our good doctor can answer a question too? Anyone?
Yeah, it's fine.
No? I'm just kidding. You guys, thank you very much. Thank you for staying around and listening, and thank you for our speakers. Have a good rest of the